Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hello, everyone, and welcome to Research Perch. My name is Doug Nelson, and I'm the president of the Massage Therapy Foundation. And I am a massage therapist in Champaign, Illinois, and have been practicing for more than 40 years. And I'm excited today to welcome two guests, Dr. Geraldine Cameron and Dr. Virginia Cowan, to this episode of Research Perch. So, Dr. Cameron, would you like to introduce yourself first?
Hi, everyone. I'm Geraldine Cameron. I'm the immediate past president of the Massage Therapy Foundation. I'm also the current dean in the College of Allied Health Sciences and Distance Education at the National University of Health Sciences. And I'm also the editor-in-chief of the Journal of Bodywork and Movement Therapies. And I'm really excited to be here to talk about this paper today.
Excellent, excellent. And Dr. Cowan?
I'm delighted to be invited to talk about my research here. I've been a massage therapist for 20 years and a massage therapy researcher for 15 years. And I published in JBTMB and IJTMB. I'm excited some of my first articles came out this year. And I most recently was at Rutgers University in the Institute of Complementary and Alternative Medicine. That has since closed. And so I'm charting new pathways to see where life takes me.
Wonderful. Well, let's go ahead and dive right into the article. And the article we'll be discussing today is the integration of massage therapy into outpatient cancer care. And this article was published in the Massage Therapy Foundation's open access and peer-reviewed journal, the International Journal of Therapeutic Massage and Bodywork, IJTMB, which you heard referenced earlier. So let me just read one little thing as a preface to kind of set this up. In this article, we learn that massage therapy is helpful in alleviating cancer-related and cancer treatment-related symptoms, and surveys have noted that patients seek it out during treatment. But little is known about the integration of massage into outpatient care. In this study, the authors examined the extent to which massage is currently being integrated into outpatient cancer care at National Cancer Institute designated cancer centers. A systematic analysis of each of the NCI cancer centers' website and follow-up telephone survey conducted data on 5 variables using a 6-point scale. The integration of massage was assessed by an algorithm where 5 variables were rated equally, and the findings of this analysis suggest that research on massage is not being leveraged to integrate massage into outpatient cancer care. So despite the evidence that massage is a viable non-pharmacological treatment for cancer and cancer treatment-related symptoms, massage was not highly integrated into these cancer centers. Efforts should be made to educate healthcare providers on the benefits of massage therapy and the important roles massage therapy can play in cancer care. A wonderful setup. I'm interested, so I'm going to go by first names if you don't mind, Virginia. So tell us a little bit about the genesis of this study, where the idea came from. How did this come about?
So that's a really interesting question. When I started work with the Institute of Complementary Alternative Medicine in Newark, I did a couple of pilot studies at the Cancer Center, and one was massage, one was aromatherapy, and our massage therapist pointed out, or one of the massage therapists pointed out that she would work with cancer patients at the Cancer Center as part of our study, and then go off into her private practice in the community and work with cancer patients who paid out of pocket to get massages. So it really got me thinking about, well, where do we have cancer centers that offer massage? And so with institutional changes, we weren't able to continue to do the pilot work or even deliver massage in that setting. But I was working with graduate students, and we started to look at mindfulness, at massage, at aromatherapy, at acupuncture, and really starting to look at that in cancer care, which is the back end of translational research. And so there were multiple projects that used these methods, specifically the web scraping methods, to go dig through websites. And we used that for curriculum and all different kinds of studies, and really refined the methods. And so what this paper reports on is sort of a follow-up study. We did one regional analysis to look at cancer care, and then discovered that we really had to not only do the web scraping, but to also do the telephone surveys to capture the full market. And then the NCI Cancer Centers was just a natural outgrowth of that.
It's very cool. And as someone like myself who's not a researcher, one of the things that I found interesting in the very beginning of the article, the Institute of Medicine, those little kind of guidelines, kind of stages of integration, I thought that was very helpful. And they are the dissemination of information, just that this might be helpful to you, the incorporation of a therapy into care, then next stage, the use of evidence-based decision-making, then the development of clinical practice guidelines, and then shared knowledge, communicating that across the board to other providers. That's a wonderful kind of framework for all of this. And certainly you see in this paper various ways that was or was not integrated. So it's fascinating.
Well, and so what was really intriguing about how this paper emerged is that the focus of this study initially was to gather clinical practice guidelines to see how massage therapy was actually being integrated and how it was drawing upon research evidence. There's so much research on massage for cancer care, and I think that that's one of the top two categories, and right after that is massage in premature infants, right? So if we look at that and think, how has that translated into care? That was part of our focus, but we were really trying to dig into clinical practice guidelines. And what happened was my co-author, Barbara Tafuto, she's amazing. She was a doctoral student in biomedical informatics with a background in library science. And we were gathering all this information. She was categorizing it, and she found this IOM report and said, hey, look, if we look at what we have in the report, and this was after we gathered our data, this algorithm literally emerged out of the data set. And the thing that was so intriguing to us is that some cancer centers are providing information about massage and saying this is great for your patients, and it's really a lost revenue stream because the patients are getting the information and then going someplace else and seeking out massage, and it's not necessarily part of coordinated care. And so if we're looking at this and saying, are cancer centers being proactive and treating the whole patient, we found some centers that were. And so that was really cheering to kind of look at this at the end of this and say that there are patients who will go in for treatments, will go in for assessments, will have the opportunity to get a massage, and it's truly part of their comprehensive cancer care. Not as prevalent as we'd like to hope, but it exists.
And I love that there were several centers that did include massage therapy. That's super exciting. Did you look at any of the evidence as to what type of care or what type of cancers actually are the ones that are most frequently getting massage care?
So we didn't ask them to provide any information about their patient population at all. Okay. We were looking at this from an administrative point of view. And if we were to try to, I don't know, get or encourage centers to really stratify, my sense is that they do that on their own as part of the cancer care, but it might be really interesting to coordinate multiple centers and see who shows up. Mm-hmm. I suspect part of that is driven by, number one, how convenient the centers are. Number two, how often the patients receive care and how you make massage available. Because one thing that we did discover is that, and this was the other part of the study was presented as a poster at AMTA, but it was digging into the guidelines and looking at what was offered to the patients. And it was a full range of full body spa massages on demand to 10 or 15 minutes during infusions, remembering that all patients don't receive infusions, and patients who might arrive for radiation treatment would be in a different area of the hospital. So I think all of this is really worth exploring. It gets to not the delivery of massage techniques so much as the design of programs. And the information's out there, it's just capturing it, I think, would be really key.
And, if I might add that, that thing of even in that first stage of this is a really valuable resource for you, but if that resource is difficult to access, for instance, if it's, okay, so you have to go seek it out in your community, that's not a little divide, that's more like a chasm, because that means that the person has to go through a whole bunch of steps to seek out, someone to help them. I would imagine quite a few people get lost in that step if it's not readily accessible to them.
And that's, again, part of what made us really want to look at this, and not to talk about the paper we're not talking about. When we looked at this regionally in our other study, we found absolutely similar patterns that we found at NCI designated cancer centers. And that is to say, they might refer you to the local Gilda's Club, or they might refer you to some other community-based resource and there's not a pathway. So that part was very intriguing. And then the other thing that I'm just going to preempt a question that people emailed me about this paper and the other paper, and people were objecting to us pointing out that Reiki was one of the modalities that was offered. We didn't ask who was delivering massage. We just said, you tell us what massage you offer, and we're going to say whatever you have on your list, we're going to pull this all together and really try to categorize it and Reiki was one of the most popular modalities. So the question is are those massage therapists, or are there other people, specifically nurses, who are delivering treatments? And if so, can we draw that back to our evidence? So all this comes back to our body of evidence and how we communicate. And that this showed us something that could be potentially problematic, I think, for us, just in terms of the delivery and the connection.
Right. You know, that's the thing that strikes me most about this whole discussion and this whole paper is we're looking at this very specific application to cancer care, but boy, some of the issues that you raise could be broadly applied to a primary physician, and we're talking about musculoskeletal pain, and they say massage is very viable. It could be very helpful for you. And right.
And now what?
And now what? And you're on your own. But you know, this is probably a good thing for you. Boy, that doesn't serve the patient in the best way possible.
Well, and so it's interesting because I've been writing for Massage Today, and one of the first articles that I wrote to them, they split into two parts because it was too big, but it was how we as providers can connect in our community, and that was specific to the pain solution. And I think what's really interesting with cancer care is there's no business model of massage in cancer care. And so if we look at that business model, part of the challenge really involves payment. And if a cancer center is going to set up a separate payment revenue stream, then that happens at some centers, and as several of the centers that were in our study, we know that exists because we know the people that we've communicated with. But payment shouldn't really be a barrier. But I mean, it doesn't fit into how one accesses cancer care, right? It's insurance card and copay, and that's it. So that's one component. And then the other piece is really how we represent ourselves in delivery of massage. And that got very confusing in trying to look at the guidelines, because licenses and certifications are used differently throughout medical care. And so we ran into this in all of our studies to say a license is the minimum requirement, and anything over and above that is not necessarily required. So there's a lot more work to be done, I think, to look at the business model aspect of this, and then taking us all the way back to one question we really didn't ask is the extent to which I guess we sort of did, but the extent to which the electronic records and the patient outcomes for massage are part of the whole patient care. And it's important that providers know that patients are seeking massage. And if it's in-house, they would know, but back to the algorithm, they're not necessarily documenting this in the electronic health record. So that's kind of problematic if the treatment isn't documented and the outcomes aren't documented.
You know, I did have a question about that in the paper. So when you look at documentation, were you interested in documentation within the hospital record or just documentation period? Because I would suspect that some massage therapists might have their own system of documentation, but it doesn't go in the hospital record where other healthcare providers would know what happened during that. So did you ask about where things were documented, or just was it in the hospital's electronic health record?
So we were specifically targeting the EHR, and again, that really came out of Barbara's background in biomedical informatics, and the notion that the EHR is really the shared record. And so we are aware, anecdotally, that there are some centers where separate massage records are kept. For example, locally, I guess it wasn't in this analysis, but there are some hospital systems that have spas. And so the SPA record is different than the patient's electronic comprehensive health record.
Okay.
So the idea that the healthcare team is communicating through the record is great, but when the massage information is not in there, or it's not written in a way that a healthcare provider could understand what happened, it really doesn't promote communication.
Totally agree.
And ultimately then doesn't serve the patient to the optimum way.
Right. And so again, we're looking at integration and saying, how well are we integrated? And this algorithm, it's applicable to acupuncture. It would be applicable to sports massage. I mean, and so in looking at that and just taking these, which we expanded, the whole IOM has 8 steps, and we didn't use all of them because they didn't show up in our data. But it definitely is worth looking at this and giving ourselves a score and saying, how well are we doing? And then the follow-up to this really should be, if we're not doing well, how can we, as a profession, but then also even with maybe collaboratives within our profession, how can we represent ourselves in a way that's going to benefit patient care? So I think I'm hoping that people see these results as an opportunity here for cancer care, but for other applications as well.
Totally.
Were any of the guidelines published? I mean, would it be fruitful to take some of the guidelines and send them to the rest of the NCI cancer centers?
So that's a really good question. The subjects of this research were treated just like any other research subject. So meaning they sent us information with the expectation that we would analyze it and not I guess, reveal who they were.
Got it. Okay.
But we did get guidelines. We did get specific written clinical practice guidelines or other information from only 11 of these centers. So the remaining centers, we had 2, I think, that said they would send them and didn't, and we were persistent with them and then they didn't respond. And many of the other centers did not have written clinical practice guidelines at all. So they were just delivering massage to patients on an assessment and treatment basis, and that was it. So that's also kind of intriguing to say, there are, among the guidelines that we did get our hands on, again, different paper, the Society for Oncology Massage has some general recommendations, but it didn't really fit, or it doesn't fit into what's standard type, intensity, frequency, duration. And that really is, I mean, that's standard for exercise, and that's more of my background. But that the type, intensity, frequency, and duration can come right out of massage research to try to identify what's beneficial for patients.
And when I looked over this, there are a couple of things that stood out. One of the things is that less than 30% of the centers actually needed a physician referral, which is pretty amazing. That was surprising to me. And then kind of the lack of clinical practice guidelines. Those were 2 things. And also that Reiki and therapeutic touch were 2 of the highest used. All those things were surprising to me. But as the researcher, Virginia, what was surprising to you in this process? Something that you did not expect?
So I have to go with item number 1 on your list, which was the lack of a physician referral. And what I would encourage you to think about is that as licensed massage therapists, we practice with autonomy. And so a referral is not required, and there really is no requirement for oversight. So that I didn't find it, I didn't find that, I guess I'm glad the number wasn't higher. But the other thing is that the lack of communication, and that what really emerged from this is that massage is in its whole different room in the basement of a building, not connected with other people, and yet many of these facilities will want to offer chair massage at events and want to bring in yoga at events and things like that. So there clearly is a benefit for employees that we don't extend to patients. And so I think this pretty clearly shows that, and it just points out some opportunity here for us as a profession to really start to leverage our research in a way that makes sense to us, so that we can communicate on behalf of patients.
Oh my goodness, that was so eloquently stated.
It really was.
Oh my goodness. I'm just kind of replaying that in my head and pressing save. That was fabulous. Wow. Amen.
So really, what is the next step then? Is it more research needs to be done? We need to come up with clinical practice guidelines. Is there something that can be done in terms of the business model right now that massage therapists can get involved in doing?
So what I would absolutely love is if there was a way to connect massage therapists working in academic healthcare with each other, and to connect massage therapists who are working in cancer care, not through S4OM's training model, but as an advocacy group for themselves, to really start to look at the common themes amongst what they do. And I mention that because the guidelines that are now getting a lot of attention were for integrative cancer care are based on a systematic review that was done by Heather Greenlee. And this was done a while ago, and it was specific, I think, for integrative breast cancer therapies, I think. But what's really interesting is when you dig back into the paper, and I've written about this before, the studies that they based it on simply looked at whether or not there was an effective massage, so they based everything in their review on a control group. And if we can draw comparative effectiveness research together and what people are doing in cancer care in particular, I think that's a place to develop the pattern to get clinical practice guidelines that don't scare people. And the not scaring people might be, hey, what if the recommendation is 2 20-minute massages per week for the first 5 weeks of cancer care? People think, oh, practice guidelines are going to tell me what to do. That's really basic. And that's something that really could be then used and marketed to centers to start to build programs. So in my dream world, that would happen. I don't know why we're not there yet, but I mean, I certainly hope we can get there.
And I would posit that this paper is a step in that direction. And the thing that's so rich about all this is this kind of investigation just leads to more questions and a deeper understanding. In the end, it's a deeper understanding for us, and it makes our practice richer, but it serves the client, the patient, in the best way possible. And that's what we're all about anyway. So thank you to both of you for taking the time to explore this today. It was a rich discussion. So with that, I might add, there were a whole lot of little areas that we could dive down and explore more. So I'd like to just reserve that possibility for the future, that maybe we could take any one of these avenues and explore it further. Would you guys be willing to do that?
That'd be great.
Absolutely. Translational research, that's totally of interest to me. So thanks so much for the interest in the paper and the research and the questions.
Thank you.
Thank you, Virginia, for the great work that you do. Thank you, Geraldine, for helping to shed some light on this today. And thank you, everyone, for watching and being a part of Research Perch. Thank you very much, everyone. If you enjoyed this podcast, please consider donating to the Massage Therapy Foundation so we can continue to bring you this and many other resources to help you deepen your understanding and practice of massage therapy. Thank you.